Welcome to NewYorkBIO's Virtual Breakfast Series, a digital program started in 2020, bringing you fireside chats with leaders from across the healthcare spectrum. This week's episode features Dr. Ethan Weiss, a cardiologist at UC San Francisco, who came to us after spending time on the front lines both in San Francisco and in New York City, treating patients with COVID-19.
All right.
Good
Well,
morning, everyone. It's 9
Go for
o'clock.
it, Jen.
Yeah, so good morning, everyone. It's 9 o'clock on the East Coast, 6 a.m. on the West Coast, where our guest, Dr. Ethan Weiss, is at the moment. My name is Jennifer Hawksbland, and I'm the CEO at NewYorkBIO. Welcome to our Tuesday morning breakfast in air quote series, because you are at home and bringing your own coffee to our conversation. We are delighted to welcome you to yet another week of great conversation with important stakeholders in our industry. And I just want to let you know, I usually give you a little update. New York is experiencing a partial reopening at the moment. For those of you who are pretty much upstate, with the exception of the Albany region, maybe having retail opening for pickup and construction resuming and some other activities resuming. Those of us who are downstate in the New York City and Long Island, Westchester area, we have a little bit further to go. So we'll all be coming to you live from home for the next, at least, foreseeable future. We have rescheduled our NewYorkBIO annual meeting for September 14th. We're certainly hoping that we can have an in-person component to that meeting at the time. It is our largest gathering of our life sciences industry of the year. So we hope you'll be able to join us either virtually or in person by that point. I'm going to turn it over to Derek now to introduce our guest. Oh, one last housekeeping. If you would like to ask Dr. Weiss questions, we have both a Q&A feature or a chat where you can send a message to the panelists. Derek and I will be fielding those for him throughout our conversation this morning. Thank you, Ethan, for joining us. And Derek, I'm handing it over to you.
All right. Good morning, Ethan. It's great to have you here. We have not trapped Ethan in a basement. Ethan has very graciously, got up very early at California time and is shielding himself in a way to protect the rest of his family. I've given due to the West Coastness here, I've given us a little homage to San Francisco in the background. Just for our guest, Ethan, is a little bit of background. We've known each other for a little while, but do you want to give everybody just a little sense of your background and where you come from?
Sure. I was born in Michigan, but I spent my childhood in Baltimore. Went away to college actually in New York State, and then came back to Baltimore for medical school and residency, and then moved to San Francisco in the summer of 1998, so 22 years ago, to do my cardiology fellowship and research fellowship, and stayed around here and spent the first part of my career mixing clinical cardiology, mostly focused on prevention, with research focus on blood clotting, and then about 10 plus years ago, moved the focus of the lab and the research to be more on metabolism, and have spent the past 10 or 12 years working in that area. And that's kind of me.
Excellent. So one of the things that we had thought here is you've been really thoughtful in speaking about COVID, really from the front lines, both in San Francisco and in New York. And amazingly, it kind of all started with one or two things on Twitter in really early January, thinking about the data surrounding the disease. And I thought one of the best things to talk about here would be some of your early interactions with patients and with the community in San Francisco, and then to talk a little bit about coming to New York City for the last few weeks and kind of the situation in both places. So, maybe we can kind of rewind the clock a little bit and set the scene in San Francisco in, say, January and February. What were things like in the city as things really started to climb up, and what were you seeing on the ground there?
Yeah, so January there was nothing. I mean, there were conversations going on Twitter. I trained at Hopkins as a resident, and one of my chief residents, the year I was an intern, is a guy named Tom Inglesby, who's become quite prominent in this, and Tom had sent out a series of tweets in the end of January that I thought were scary, but these guys are always kind of scary. I mean, that's Tom's business, is to be scary. So I think we spent the majority of sort of the end of January and February trying to kind of figure out how much to pay attention. It was interesting you go back and you look at what happened. The first patient admitted to UCSF was on February 4th, which was Super Bowl weekend.
Mm-hmm.
It was a long time ago, and the there were patients in and out of the hospital throughout February, but I don't think anyone here in San Francisco was terribly worried about it. In fact, I remember going to a big UCSF event for donors, and the chancellor got up and talked about it, and he was sort of a downer, and I think everybody was like, why is he bringing everybody down? But his kind of response was, everyone says this is not going to be a huge impact here in the United States.
Yeah, well, that didn't really age well, now did it? So it's funny you say, oh well, February 4th, that was a long time ago. It's I think about this now. I think back to the middle of March when things were really escalating. It's 2 months. It's actually not all that long ago. And
yeah.
I think the thing that you look at in hindsight is you look at the numbers and you think about how quickly the escalation happened, in particular in, say, Seattle and San Francisco, right? We, in New York, we had, we saw this happen, and we knew it was coming here or there, but we got to see the initial reactions from Seattle and from San Francisco.
Yeah, it was. It started to get a little bit more interesting here towards the end of February, beginning of March. I think it got real for me because one of my kids' schools was closed because there had been an exposure to one of the passengers on one of these. I can't keep track of which cruise ship, but it was one of the Princess cruise ships, and so her school was closed. So my 7th grader school was closed for 2 days. I think it was either very end of February or very beginning of March. And so that was, got a little bit real, and people started to pay more attention. And there was definitely the outbreak up in Seattle, and there was stuff happening down in Santa Clara. So it felt like there was definitely disease around. I remember my niece plays lacrosse, and she and her team for college, and they were supposed to come out here to the Bay Area for spring break. And I remember having conversations with my sister. They were going to be up in Davis, and there were, I think some of these patients were taken to Travis Air Force Base, which is close to Davis. And then I think there were a couple of cases of community transmission that people were like, well, that's weird. That person didn't have any contact with anyone from Asia or anywhere else. Ultimately, of course, they did come. It was bizarre. They came, they were here for like 2 days, and then they got sent back. But things did escalate very quickly here. And I think that's when, for me, it became real. I think it was the week of March 7th. We had we started to have these UCSF wide town halls. And I remember it was a Friday afternoon, and I remember that they had announced a new travel policy. And that was that basically you can't go anywhere. And I thought, wow, that's pretty severe. Like, they literally said you can't go anywhere. And I thought, okay, they must know something that I don't know. And then, of course, that Monday was the day that March 16th was the day that the 6 Bay Area counties locked down for the first time.
Yeah, I think the exact same weekend we were at a hockey tournament, and we knew everything that was happening in California. It was a week or so before our annual meeting was supposed to happen, and there was this eerie feeling of things were happening on the West Coast, but there was this eerie feeling of should we, are we safe to be here? Should we actually be here? Things were starting to tick up in New Jersey. Things were starting to tick up in Manhattan. And, we had spent really the next week figuring out, whether and how we can basically take our annual meeting virtual. And then really everything just, escalated within the span of the next few days. And, we ended up postponing the meeting, but all of the hockey tournaments next weekend were canceled. But in hindsight, the speed at which everything escalated was intense. And you look at how quickly you went from maybe being a little nervous to full on stop, and that really really changed a whole heck of a lot of things. So as over the next few weeks, can you talk a little bit about where the push to come to New York came from, and just kind of some of your observations internally around how San Francisco was dealing with the spread, and really where the motivation came from for UCSF to send a group of people to New York?
Sure. So, like I said, that weekend, the Monday, March 16th is the day that everyone remembers, because that was the day that the county health commissioners and the mayors of the big cities here all closed things down. I think schools had closed down the week before. There was still some like weird, we were all doing this dance, right? I mean, my younger daughter plays competitive basketball, and she was at a practice on Saturday. And I remember my wife and I looked at each other and thought, this is stupid. Like there's no way they can be socially distanced.
Yes.
They're all over each other. And I mean, they were, throwing elbows and sweating and using the same ball. And so we ended up not sending her on Sunday. She was supposed to go on Sunday, and we got sort of a weird response from the coach. And then of course, Monday, everything closed. I had been
same scenario with jujitsu. So
yeah, you can't really socially distance.
That's not a socially distant sport.
Yeah, it's not going to work. But I had also gotten an email that Sunday from a colleague of mine who was supposed to be on the clinical service, cardiology service at UCSF that following week. And that person had said that their doctor recommended they not go into the hospital because they were at risk. And they asked me if I would be willing to cover. And I said, sure. And then, Monday the shutdown happened, and I was going to go in on Wednesday, I think, and had to go get tested for an N95. I had to shave my beard, that whole thing. And I remember thinking that was a pretty uncomfortable time. I was scared. Going for my fit testing was probably most scared that I've been. It just felt super bizarre and weird. And I remember like trying to figure out if I could actually smell or taste the noxious stuff they use. And then I went into the hospital, and everybody, and it was a strange experience by nature of the fact that there was no one else there. I mean, there were no visitors. There were very few patients. They'd emptied the hospital almost completely out. We had all kinds of protocols that were developing over when to use PPE and when not, but it was a very bizarre time. I think there was quite a bit of kind of fear early in the week. And then as the weekend came, I think we got bored. And ultimately, I don't think I said it. I might have thought it, but I didn't say it as early as that weekend. But within a week or so, probably the following weekend, March 20th or something, I did start to wonder, when can we, know for sure that the lockdown has actually had an impact here? In other words, when can we start to think about whether the surge might not come? And by that time, it was obvious that there was a big surge happening there in New York. Mm-hmm. So I would say, within the sort of end of March, around when I, by the way, was not just looking at, the public numbers. I was looking at the census and the emergency department. I was looking at everything I could look at that I thought might be a leading indicator of whether we were going to see a surge. And there was just not any evidence at all. And in fact, it was flat, completely flat. And so I did start to wonder, gosh, maybe it's not going to come. And, sometime in the end of March, started to ask our group if there was going to be, an opportunity for us to go help out people who needed the help. Clearly, everything was hitting the fan in New York, and there were other hot spots, I think Detroit and New Orleans and other places. And so I felt like, gosh, we're spending all this time and energy. We were meeting at that point twice a day and making all these contingency plans. It just felt like an enormous amount of energy being spent for something that didn't seem like it was actually going to happen. And the response that at that point was, the surge is coming here. We can't afford for anyone to go anywhere. You got to be here. And that continued on for, several weeks. And then I only heard about the group going from UCSF to New York in the middle of April, when it was announced they were going to leave the next day. Wow. And my response to that was, wow, like, amazing. I'm so proud of everybody, but also I'm jealous. Like, I just felt like I had been activated, and I wanted to get in there, and I wanted to pitch in and do something. And I think we were all trying to find ways to keep ourselves busy, and everybody was repurposing themselves as a COVID expert. And I struggled with sort of, well, do I do that? And do I kind of rekindle my interest in clotting and all this other stuff? But ultimately, I sort of couldn't shake the idea that I wanted to be helpful, legitimately helpful. Even as a cardiologist, I felt like I could do something, because of my experience taking care of sick patients. But again, asked, is there a reason, can we go? And was told not. But then a week later, they did finally say, you know what, they are asking for volunteers from cardiology.
Mm-hmm. That's excellent. So okay, so now you've kind of made the decision that you're going to go, and I imagine there's some family discussions that happened there. I don't know how easy that was as a sell to the entire family and be like, okay, listen, good news, it doesn't look like it's really going to be quite as bad as we thought it was here. Also news, it's going to be really terrible in New York, and by the way, I'm going to go to New York.
Yeah. I don't think it came. So first of all, it wasn't a decision. I didn't make, I guess it depends on who you ask. If you ask my wife, she says I'd made up my mind. But I, at least consciously, wasn't going to go unless I felt like I had the support of my family. And really the support and buy-in from all of them. I think the kids were, they were not terribly worried about it. They ended up getting worried about me coming home. I think they were worried I was going to bring it back, but they weren't worried about me going. I don't think they were nervous. Maybe it says something about how they feel about me, but they weren't nervous about me getting sick. I think my wife, basically she knows me well. We've been together for 20 years. I think she knows me well enough that she could kind of see that it was something I felt like I had to do. And so it didn't take her very long to kind of arrive at least saying that she supported me. Whether she actually deep down supported it or not is a different story. And look, I was very fortunate. I think it was my kids are 16 and 13, and they're relatively self-sufficient. And there wasn't a lot going on that I was couldn't leave for 2 weeks. It felt like an opportunity where, like, look, I can do this now, where it's not like I've got meetings or anything else critical that can't just stop for 2 weeks. And so it felt like it was an opportunity to do something that I otherwise at a different time in my life couldn't have done.
Yeah. So I had the other day I had posted all of your posts from kind of each step of the trip. You had the initial one when you're just getting on the plane and getting ready to go, and I think it'd be so. What was it like literally walking into the hospital for the first time? You come in, you've got a strange hotel room in an eerily quiet New York City, right? There's, it's still pretty desolate. It's a little bit better. There's a little more activity now, but you're in a huge but now desolate city, and you stepping into the hospital.
Yeah, so it was a strange experience. So UCSF had sent 20 people out on I think it was April 14th, and then there was a smaller group of us, that was 4, who came out on the 28th, 2 weeks later. So we were there for just 2 weeks. We went out together on the airplane. There was sort of, they had kindly upgraded us to first class, so we're sitting within a few feet of each other, but we could stand up and talk to each other. We rode to the hotel in a van. It was a big van, but we were talking. And we get to the hotel and we go our separate ways, and basically we're like, well, that's the last we're going to see of each other. I think we ended up doing a bunch of Zoom calls with each of us in our hotel rooms, which is strange.
Ethan, were you all at different medical centers?
We were at 2 different medical centers. There was a group of us, small group of us in Manhattan, and then a much larger group who was at a hospital out in Queens.
Okay.
And then, within our hotel, it turns out there was another group of healthcare workers. I think it was mostly nurses, but a few doctors and RTs who had come down from a hospital up in Ithaca. There were, I think, 50 of them also staying in the hotel. So the whole hotel was healthcare workers. Also kind of strange. The whole hotel experience was odd in its own way. Yeah, and then Sunday I walked up to the hospital to meet the person who was going to kind of introduce me to everything, and he showed me around and showed me the little office that they had set up for me, and walked me out to the wards. And I mean, I was obviously unlike anything I'd ever seen. It was a little scary, although not terrifying. And then I went back to the hotel and got ready to go to work the next day on Monday.
Mm-hmm. What were some of your first impressions of kind of stepping onto the ward, stepping into the hospital? You had the way that you describe it, and I think one of the things that originally struck me, and I think probably strikes a lot of people, is I don't think people realize how long patients spend in the hospital when it gets serious.
Yeah. So I had, one of the things that's interesting about the way that this hospital had kind of adapted their normal processes was that there was there was a attending cardiologist in the hospital. There were actually 2 of them. When I got there in April, there were still 2 overnight and 4 during the day. And so it was all 12-hour shift work, which ends up being 13 hours because you're signing out on either end half an hour. So I had gotten detailed sign out from the person I was taking over for on Sunday afternoon. And so I heard about these patients, and I remember thinking, wow, these are complicated, sick people. There were 10 people. At that time, all but 2 of them were intubated and had been in the hospital for a really long time. So I showed up on Monday having a picture in my head of what I was going to walk into. And it's funny because we walked out to the ward, so the first day they had paired me up with this cardiologist who basically was going to be my buddy, and he would work with me that day, and then the following day they would set me free. And so the look on his face was sort of like, this is really unusual. There was a lot of activity on the ward that morning, like lots of stuff, people in like full PPE, but like PPE that you would see in like a nuclear power plant kind of thing. Like it wasn't what I expected, and just like people all over the place and just lots of stuff happening. So it turns out that of the 2 patients that were not intubated previously on my service, both of them were getting intubated at that moment at 7 o'clock in the morning on Monday morning. And so that was my introduction was, okay, well, I guess there isn't going to be anybody extubated. So it was strange. Now, this person who was helping me, orient was clear to me that this was not normal. But it was an exciting way to start the week. Lots of activity.
Yeah. Can you talk a little bit about how, so how were the teams in New York kind of dealing with all of this? Because I know some people that have been, that have either had their roles switched or whatever and put immediately to the front lines. And it seems like it's just been an incredibly long grind for everybody that's been there. And, I don't know if people have now reached the point where they've gotten into a routine and they're kind of steady state, or I don't know if people are kind of looking for, the light at the end of the tunnel when things start to die down. What's morale like, and what's it like to be part of an operating team at a hospital now?
Yeah, I was stunned at the level of commitment, dedication, morale, energy, resilience, whatever you want to call it. That I don't think I heard one person complain the entire time I was there. I don't think I heard one person anywhere complain about anything, whether it was how tired they were or PPE. The majority of people that I was working with had been redeployed from other areas. I mean, these were people who, I'll just say, there were a couple of electrophysiologists who were, typically putting in pacemakers and doing, complicated electrophysiology studies. There were a couple of people that had graduated early from their pulmonary critical care fellowships, and they had been working in the lab, literally like, working, with like knockout mice, and they had been redeployed. We had a hematology oncology fellow who had been redeployed to be an intern on the service. No one complained. Everyone was just doing their job. Tons of volunteers. I mean, it was fun to see people from all over the country coming and pitching in. And again, the thing that struck me was that no one even looked tired, which was so strange because it's exhausting work emotionally and physically. But I was really amazed by how everybody was dealing. I think towards the end, as things started to die down and as people's adrenaline started to wane, I could sense that might start to change, because they were in the process of sort of unwinding all of the things they'd put together. And I think maybe at that point, people would start to reflect a little bit. But I didn't really hear anyone complain at all. I was amazed.
I also can imagine that people's energy levels, dropped pretty precipitously once they left the hospital, right? You have, it's one of those things you kind of have a way of getting up for what you need to get up for, but the bill kind of comes due when bedtime hits an hour early or something like that, and you kind of have to get up to do it again. So I don't think people weren't necessarily begging for nightlife after they left.
No, I mean, that's the thing about this kind of of shift work, which I'd never done before. I mean, I guess I'd done it in the emergency room or something when I was a resident, but I'd never really worked these 12, which are really 13-hour shifts before. And the way it works, right? I mean, I would leave my hotel, I'd walk up to the hospital, I'd leave around 6, I'd get there at 6:30, get a cup of coffee somewhere along the way. And then I'd be there until, sign out was at 7, we'd finish at 7:30. I'd walk back to the hotel, I'd get back there at 8, I'd eat dinner, take a shower, and go to bed. I mean, there wasn't really time to do anything other than, I'd catch up on some emails and stuff. So it's a busy it's a long day.
It is a long day. Do you think any of this changes the way that we think about medicine or anything? What do you think changes kind of going forward here? Do you see any of this stuff really kind of ticking up in terms of practice, whether it's telemedicine, whether it's the different way we think about people's shifts in a hospital, or really what we do in a hospital? Do you see anything here really kind of changing the conversation about how we practice medicine?
Yeah, sure. I mean, look, the telemedicine thing I think is going to be here to stay, right? I have this conversation every time I see a patient with a video visit. Even this week, we'll talk like, is this the kind of visit that we would, if we could be in person, would we want to be in person? And as a cardiologist, I think there are patients, it would be really nice to use this stethoscope thing that we all learned how to use, but frankly, it's probably not necessary. It's definitely not necessary all the time. And for the kind of practice that I have, which is based on prevention and lots of talking about lipids and labs and things like that, it's certainly not going to be necessary every time. So I think that will probably change. And I was as skeptical about that as anybody. I love being in the same room, and I love connecting, and I love physical touch. I mean, I thought I'll never do that ever. It's just not going to be for me. But I think I probably will. It certainly is convenient. It's much more convenient for patients. They don't have to get in their car and look for a parking place, and saves them a lot of time on both ends. And frankly, it's a lot more convenient for us too. I mean, it's a much more efficient, from a time standpoint. So that will definitely change. The hospital stuff, I mean, I don't want to go on forever, but I'll say two things. One is I think we'll certainly learn from how we responded to this. And I can see even at UCSF where there never was a surge, I think the hospital is incredibly well prepared. They were able to open up a hospital that had closed in 2014, Mount Zion Hospital, when our new hospital at Mission Bay opened. They were able to open that up in a month. I mean, that's
wow.
Like unheard of, right? And they're going to use it to treat COVID patients. I think, there's lots of process stuff that I think we'll learn. I do think that there are going to have to be some kind of elements in place to make sure that people who are not trained specifically for, something like taking care of patients in an ICU who have ARDS like me, that there's a capacity to kind of get people trained up quickly. I think that'll happen. And again, I'm impressed by how quickly it happened in New York. I was blown away by how some of these people who had no real training in taking care of these patients seemed like experts when I got there. And I probably it probably would have looked the same for me. And then the last thing is, and I think this is the most important one, and I've said a lot about this and I'll say more, but I do think that we have to build up some infrastructure around clinical research that is independent of the clinical operation. And what I mean by that is that I think if you look across the landscape of, what clinical trials have been done today and potentially are, getting done, and the numbers I think are low. And that's probably because in the places like New York City, where, they got run over by a truck, there was just no one there who really had the time or energy or capacity to be able to think, all right, well, let's spin up a clinical trial to test, drug X versus drug Y or drug X versus placebo. And so I think one thing I would dream about is that there would be some sort of a national infrastructure of an clinical trials operations that could sort of roam around where these outbreaks are. Because once the outbreak is over, like now doing clinical trials on hospitalized patients in New York City, sort of that time has passed, right? It's almost too late. So that would be my hope in the future, is that we could have some real infrastructure to be able to do good, rigorous clinical trials.
Yeah, I think go ahead, Jennifer.
Oh, I was just going to say, we actually have a question that I think is appropriate here, because we've talked a little bit about the differences in sort of San Francisco and New York. As you said, New York got run over by a truck or bus, right? And the question is this: why do you think San Francisco, with obvious similarities like demographics, population density, urban levels versus suburban, appears to have mainly avoided this sort of mass surge in demand on hospital capacity better than New York? at least New York City?
Well, I don't think anybody knows. I'm happy to speculate, which, like, I put in quotes to my kids, it means I'll guess. I think, everybody said, oh, it's population density. And when that story was sort of spinning around in social media, I went and looked, on Wikipedia, like what are the highest density populations in cities in the United States? And so, yeah, New York is far and away the highest, but the second highest is San Francisco. So it sort of felt like, well, that one doesn't explain it. And people would say, oh, it's, public transportation. No one gets on public transportation. I think, nothing is like New York City, but compared to Detroit or New Orleans, I think there's more public transportation use here. And certainly, even LA relative to San Francisco has a bigger outbreak, and it's not like they're using more public transportation down there. So I don't think that's the explanation. I think it's mostly, if I had to guess, I think it's mostly around the timing and the severity of the distancing that happened. And I'm nowhere near a mathematical modeler. I barely can add two and two, but there have been people out there who say that, the models with exponential spread, that the models would predict that several days on either direction could make a gigantic difference. And I mean, there's no doubt that I think one of the things that everybody got lulled to sleep about was because we had disease in San Francisco in the Bay Area and on the West Coast, we knew there was disease here. There was some testing, not enough, but there at least was some testing going on. There was no testing going on in New York, so everyone just assumed there was nothing there. But clearly there had been community spread in New York back, I'd guess back as far as February, maybe even January. And so I think it looked like it came out of nowhere, but it had been there. I mean, I've heard stories about emergency room doctors, having patients with this sort of bizarre pneumonia that was negative for influenza back in February and stuff. So I think it was probably just already there. Plus you add up all of the factors that, contribute to what happened in New York, and you get what happened. And then, I mean, remember that I don't know, I've heard different accounts of this, but I think the actual shutdowns of schools and, stay at home happened in New York City at least 6 days. And I've heard up to 10 days after it happened in San Francisco. So, if it had been 10 days before, maybe we would, wouldn't have happened. Who knows?
Right.
Yeah. And it's interesting that you mentioned before the need for kind of more efficient ability to conduct clinical trials. We had, early guests, both Craig Litzat and Irfan Khan, talked about this a lot, where first of all, they said virtually every single clinical trial right now is just about in rescue, right? Everyone is rethinking about ways that they're going to enroll their clinical trials, ways that they're going to reach patients. And, I think one of the things that this is really giving us if not a blueprint for it, it certainly highlights the necessity of, how do you reach patients? How do you get data? Where do you get data? And, have we been a little too married to kind of the, discrete sites and hospital-based data collection for clinical trials? How do we think about, designing them either for better endpoints or for better continuity from, when we start and how we progress?
Totally. Sorry, I didn't mean to interrupt. No, go ahead.
That's okay. I mean, the other thing too is if you think about testing and the way that we, attempted to roll out diagnostic testing and what we're seeing now with antibody testing, I think it's really it's a referendum on if you're going to do a large scale, data collection exercise. There's a lot of things from an infrastructure standpoint that need to be in place for it to run efficiently.
Yeah. I agree with everything you said. And I think, even just the simplest thing, like getting consent on an intubated patient who's been in the ICU for a month, whose family is not allowed to be there. How do you do that? And, I've heard stories from colleagues of mine in New York that they were treating the actual physical consent, assuming a patient could sign it, they were treating it as, COVID positive and had to go through some decontamination process. So these are all things that you couldn't have anticipated. And I think your point about not having these individual, the thing that I sort of pay the most attention to is this clotting thing, this thrombotic, this sort of story about blood clots. And, I've looked at probably 7 protocols at different hospitals around North America, US and Canada. And I mean, they all look sort of similar, but they're not exactly the same. And it sure would be nice if you could have, not everybody reinventing the wheel, especially because there are all these challenges, and lots of people are thinking about the same things, and it just feels like this is ripe for something. I don't mean to be like a big government liberal, but this is one situation where like it feels like the government could really contribute something here meaningful. And I don't know what that looks like. I've tried to go through the exercise of kind of dreaming what it might be, but there's just no way that doctors on the ground are gonna have the capacity to do this as, you know, the surge is coming. And then once the surge is over, then like you say, patients are gone. So it's a tough one. I don't know the answers.
Yeah, I think one of the other things that this has highlighted is how we get data and information, whether it's as scientists or whether it's as regular people. Things travel around the world very, very quickly from an electronic standpoint, and we have the benefit of following each other on Twitter, right? So I have I heard a lot of your stuff early, and there's a lot of people in that circle that I think had really pretty intelligent takes on what was happening from a data standpoint. But we've reached the age where there are so many different sources of data, it's hard to actually find a level of validity and get that actually communicated really, really effectively, right?
Yeah.
So I don't know how that changes in the future. The NIH and others have, and the CDC have the ability to push out information, but it's always a balance of when is too early, what are you sure about? So it's a challenge going forward of how and when and where are we going to actually get information, both for the people who are on the leading edge of things, and certainly for people who are in the masses. How do we disseminate all that stuff to everyone?
Yeah, and I think all I can say, I don't have an answer, but all I can say is that now that it appears we're going to be in this sort of lull phase. And look, I would be the happiest person. We'd all be the happiest people in the world. It just goes away, right? No one. I think this is the thing where somehow there's this like idea that some people are enjoying this. No one's enjoying this. Everybody wants this to go away. I think but I would say this: we have to take this opportunity, this next few months, no matter whether it comes back in the fall, no matter whether it comes back bigger in the fall, no matter what happens, we got to take this opportunity now when there is this pause and everyone can breathe to do something. Because what I was struck by in New York, and again, this is not even remotely a criticism. I think I have the utmost respect and admiration for all of the people there taking care of these patients, but I do feel like they were all flying a little bit blind when it came to making clinical decisions around using drug X or drug Y or protocol X or protocol Y. And I think to some extent they were kind of making it up, and I don't think they had a choice, but we shouldn't be left in that position again this time. That would be my kind of one preachy thing.
We have a question about, do you have any comments on the new outbreak in children that may be COVID related? Certainly we've seen I think we were at least over the weekend, we were at about 115 suspected cases in New York being investigated.
Look, I took care of 20 patients over 2 weeks. I've read a lot of the case series, and I think what I can say with certainty is that this is a bizarre disease, and there are some things that seem to make sense and fit our pattern recognition, and some that make no sense, and then some things that are sort of appearing later that weren't described in places like China or Europe. I do think even in adults, there are some patients. There were a couple of patients I saw when I was in New York over the past few weeks that appeared to have what to me looks like really, really robust vascular inflammation or vasculitis, and I say that because they had tremendous amount of clot burden out of proportion to their lung disease. So I had one patient in particular who had clot everywhere. She basically clotted off her aorta and had infarcts in all of her major organs, everyone you can think of. And, when you hear about this patient, you think, oh, well, this is going to be like the sickest of the sick. This is going to be somebody you'd put on ECMO. They're going to be, have the worst ARDS. she had the most mild lung disease and was actually the only patient in the entire time I was in New York who I spoke with. And when I met her, she was sitting up in bed having a cup of coffee and eating breakfast. And so I think, to me, what that says is there's something else going on in her. For whatever reason, it's focused on, the disease activity is focused in the blood vessels. And so I wasn't surprised to hear that there's something going on related to blood vessels or inflammation in the blood vessels in children. My guess is it's probably happening in adults as well. We haven't been looking for it. So I don't know enough to say more than that, but I'm not surprised by this, given what I saw.
Okay, we have another question on remdesivir and hydroxychloroquine. And I don't know if you've had any experience, and obviously you've thought about these things because quite frankly you've had some of the best takes on social media on what the data was and where it seemed to lead to. But we can almost broaden this up to any sort of therapeutic intervention now, right? One of the challenges that I think a lot of doctors are going to have is we have these patients, either whether we're dealing with a reemergence or not. There's a couple more things that are in the toolbox now, or at least coming. How do people actually think about the different things that they may have in their arsenal in terms of individualized treatments for patients?
Right. So there's the how would you behave in March and April?
Yeah.
And then there's the how do we behave going forward? I think remdesivir is the only. I mean, look, I was busy for a few weeks and didn't read everything, and I probably missed some things. But to my understanding, it's the only really robust clinical data we have. I think the trial was really well done. I think there's lots of academic arguments about whether it should have been stopped early. I don't really care about that much. I don't think anyone would say that remdesivir is a game changer. I don't think it's a cure or anything that's gonna dramatically impact the course of disease in an individual patient or in society. It certainly appears to be beneficial, at least based on what we've heard, and also appears to be safe based on what we've heard. So I always ask myself, is this something I would want to take if I were sick? In this case, probably, sure. But I will say this, when you can't get it, and there were cases, times in the hospital in New York where we couldn't get it, no one seemed to care that much. As to everything else, I don't know. I mean, it's again, back to what I was talking about before about the clinical trial infrastructure. We unfortunately just don't have data on anything else yet. And so right now it's just sort of trial and error medicine. I think people are using things, they're building protocols, they're trying to react to biomarkers, they're trying to make decisions based on the presentation, based on what the biomarkers look like. And so, the questions around, so I don't think anyone really believes that hydroxychloroquine works. And in my time in New York, I didn't see it once. So I sort of set that one aside, despite whatever we heard from the White House yesterday. So
you wouldn't advise using it prophylactically.
No, and in fact, just before we got on this morning, I just tweeted very briefly a update from the NIH that came just a week ago today, and they also don't recommend using it. So no, I wouldn't take it prophylactically. I mean, I don't know. And then there are the other drugs that people are thinking about. So there are all the inflammatory modulators, so tocilizumab, anakinra, glucocorticoids themselves, so steroids, and then there's all the antithrombotic stuff. And I would say that really we're still at the stage where no one knows. And all we have is individual anecdotal experience, which I think isn't meaningless, but it certainly is not the quality of data that we'd all aspire to want to have.
Yeah. So actually we have a question that just came in, which I think you have almost answered, but it says, where do you think physicians are in the overall learning curve for treating COVID-19 patients presenting with all of these various symptoms?
Well, I'm impressed. So I think again, I had a very biased experience. I was seeing the sickest of the sick people, all patients with very significant, severe COVID ARDS on ventilators for a long period of time. So I was impressed by how well these patients were being treated. I think it's somewhat as a reflection of the fact that we've learned so much about treating ARDS over the past 20 years, and that's directly a function of the fact that there was a group of people in the sort of pulmonary critical care anesthesia world who decided that they were going to do robust and rigorous clinical trials starting back in the 1990s, I think. And they've developed this RSNet protocol. They sort of came up with and tested this idea that you could use low tidal volume ventilation in people to try and reduce the lung injury. And I think that works. And we know it works, actually. And so I think that's been, I was impressed by how well that seems to be working. Obviously, it's tricky. It's still very tricky. And the thing that struck me, having not spent a lot of my life ever thinking about this clinical management problem, is the dance you do between the ventilator and the sedation. And I think it's something that people don't always appreciate, which is that the idea that you're going to use a very low volume of air to inflate the lungs to try and protect the lungs from the injury that would otherwise happen if you overinflate them, that is not a comfortable feeling for us humans. It feels like we're starving of air.
Yeah.
So you have to sedate people heavily, and even often beyond sedation, you got to paralyze them. And so then all kinds of things happen as a result of that, right? I didn't imagine that we'd be dealing with like opiate withdrawal, or people's guts stop working because of all the opiates that we're giving them to sedate them. And getting people then off the ventilator means getting them undelirious, right? Because they've all been completely sedated with a bunch of opiates and other stuff. And that's the tricky part. That's the art of this and not the science. I found that the people there doing this on the front lines were getting better and better every day. I was impressed.
I think one of the interesting, challenges that we're going to have eventually is, number one, are we able to start to understand what immunity looks like in various patients? And that's going to be probably a more individualized thing than we'd like to think about. And the dance between immunity and vaccination and that rollout, right? We've had the diagnostic testing. Now we're into thinking about what antibody testing looks like. And ultimately you can look at whatever we're going to call round 3 is eventually we think about what the vaccine profile looks like and how we might be able to distribute those things. So it really seems like we're going to have, another, wave is the wrong way to put this, but another opportunity to think about, how do we actually test these things? How do we actually think about the data that we have and what does it mean? Because a lot of it, whether it's an immunity passport or whatever it is, a lot of it has a lot of individual repercussions, right?
Yeah.
How does this affect how people can live their lives?
Yeah, I don't know. You're right. That's going to take a lot of nuanced thinking. I will tell you this anecdotally, that the 2 people I knew who were had been infected at the hospital where I was working and were back at work, they were probably the most careful of anyone I encountered in terms of PPE. Like there was a range of PPE, right? There were some younger residents and interns who were really loose about it. They would wear just like a surgical mask, and they'd put on an N95 if they were going in a patient's room, but they were not, they were pretty loose. And then there were some people who were like, covered head to toe, gloved, multiple fit masks and, everything else. And I say the 2 people I know who were infected, who had antibodies, were probably more in that sort of second camp of being really careful. I don't know. And then the immunity thing, or I think I had an interesting conversation yesterday with a phenomenal HIV doc who's, worked in clinical trials for decades. And his take, and I think this is probably my take too, is he thought it's astonishing that we still are at the point of this disease where we don't know whether you want more or less. And, we don't know whether we want to turn up the immune system or turn it down. Yeah. And that's amazing, right? We really have no idea. And so again, it says the same thing, that I'll be a broken record. We just have to do the trials, because the fact that we just have no idea now. I mean, there are probably half the world probably thinks this is a problem of an overactive immune system and the cytokine storm and all this other stuff. And then there's a group of people out there who think it's the opposite. And so I don't know.
Yeah, we had a question on whether you think that cell-based vaccines are likely an option. I know there's a few different angles, and Moderna just posted their phase 1 data yesterday on only a handful of patients. But it seems like, at least, there's a lot of smart people that know how to develop vaccines doing this, and it seems like we may have a couple of different angles to have in the arsenal. Do you have any opinion on either of those, or I know it's all super early?
I wish I could be helpful.
Yeah.
My cumulative knowledge about vaccine development is probably, you could scrape it off the bottom of my shoe. I know nothing. Yeah, that's one where there are a few times in my life where I felt like, you know what, I'm just not learning that. And vaccines, maybe I'll change my mind someday, but I don't know anything about the vaccine story. Somebody else is going to have to help you with that one.
Okay.
I can't wait to get that, have it be here and get the shot, and I hope it works.
Yeah.
Lots of smart people working on it, but I don't know anything about it.
Yeah.
We do have a question about data collection in the hospitals. It says here, we've heard that due to patient volume in places like New York City and other hard-hit areas, the data collection hasn't been, we'll say, stellar, right? And that data could undoubtedly be valuable as we understand the disease, including patient variability, pre-existing conditions, durations of sickness, et cetera. Did you see ongoing efforts to increase the data collected both from patients that have died as well as recovered?
No, but I wouldn't know that. I wasn't privy to kind of all the things that were going on at the higher levels. I didn't get the impression that it was a big priority. I don't get the impression it's a big priority here, to be honest. I think it should be, again, some sort of a way to collect all the data would be great across institutions. How you do that in the modern era with HIPAA and all the other challenges and the interoperability and different EHRs. I don't know. I don't have an answer, but it is, the instincts are good, right? We have a lot to learn.
Yeah. Here's one more question. And actually, I think this is something that you are well suited to answer. What mental health help would you like to be improved for frontline healthcare professionals?
This has come up a lot recently, and it's funny, we did here, our cardiology division put together a webinar last Friday, talking about sort of the mental health impacts. And it was, they asked me to speak, and they had a trainee speak, and they had a young woman who was a research assistant speak, and then another administrator. And it was interesting to hear everyone's take on this. I'm just happy we're talking about it. I think it would be, it's fantastic. I think the story of the emergency room doctor at Columbia probably made a huge impact on people. I think, I don't know, I'm still sort of sorting through my emotions of what I saw and how I think about it, and trying to untangle the sort of direct impact of, the sort of trauma and bad things that I saw from being away from my family, from how am I going to carry on my life going forward, and are we ever going to be able to reopen our labs, and what's going to happen to from a financial standpoint, are my kids going to go back to school? I mean, there's just a lot. I think we're all dealing with a lot, and all I can say is that I'm happy that we're having the conversation. I think we need to continue to have the conversation and destigmatize the fact that it's okay to talk about our emotions. I think it's really important. I think maybe that's going to be one of the silver linings, is that we all end up kind of getting better at talking about this stuff. But I don't have any specific.
Yeah, that's definitely been a focus, both healthcare as well as just the general population, particularly here in New York. The governor's partnered with a couple of several different entities that are trying to provide available healthcare, mental health care services to people where they need the most, which is from their homes right now.
They've offered it to us. Actually, they did. I told you about these Zoom calls. We did a couple where we did a guided meditation, and I don't know. I'm not sure how helpful it was as a group, but they definitely offered it. They've said that it's available to any of us individually if we want it, and I think that's good.
Yeah, I signed my kids up for one and didn't go over too well, but
my kids wouldn't. Well, and the fact is, they're angry. I mean, I got home the other night. We had this. It's been weird to come home, right? I can't. There was sort of this. I alluded before that my kids were a little bit nervous about me bringing this thing back, and so I'd spent a couple of days in quarantine, and then got tested and came home, and I think they were a little trepidatious about me being back. But then we were having dinner one night, which was great because it was the first time in 3 weeks we'd sat down to have dinner together, and we started talking about what the next phase looks like for them, and they're desperate to get back, to being kids again and like being able to hang out with their friends. And I sort of callously said, I don't see it happening anytime soon. I mean, I think I was just too harsh about it, and specifically, kind of around like when they could not wear a mask. The kids just don't like wearing masks, and they got mad. They got really angry. Like both of them got like really mad at me. And obviously it's a lot of stress for them. I think they're, they never dealt with anything like this before. And I do think, and it's one of the things I said when I was in New York, I do think that one of the things that's missing from this for most people is visibility into what it looks like. And so that was one of the things that I have the, opportunity, I guess is the wrong word, but I was able to see it all. So I think it's easier for me to kind of accept like wearing a mask is trivial. Like if it means that I don't end up like all these patients I was just taking care of, or that people around me don't end up like that, then that's a small price to pay.
Right. We only have a couple of minutes left, so we do have two quick last questions, so we'll keep them very brief. Did you treat any patients with donated plasma, and did you see an impact if you did have any patients that have been treated that way?
I didn't see anyone who got convalescent plasma. I know there are trials going on everywhere in the country, including here at UCSF, and I haven't heard anything yet in terms of what impact it's having clinically.
And then next one is, do you have any thoughts on the role climate or temperature may play on COVID-19?
Yeah, I mean, this is where like everyone's an armchair virologist and epidemiologist these days. I don't know. I guess typically there's seasonality to the flu.
Yeah.
And I would imagine that we'll have a similar thing here as well. And we'll figure that out pretty quickly, right? I think that I've heard from people in the Southern Hemisphere that they're sort of, bracing for what will be a bad summer for us, winter for them. And again, I expect, and maybe, hopefully we're all wrong, but I would operate under the assumption that this thing is going to come back in the fall. I heard something yesterday that Notre Dame University has decided to go back to school, and they're going to have kids come back in August, and they're going to stop at Thanksgiving. So I think they're also anticipating that there will be some seasonality to this as well. So my guess is that there will be an impact.
Yeah, my husband and I actually were talking about that last night. And our issue for New York, a lot of New York schools, is we don't have air-conditioned schools. So to start much earlier in August is hard.
Yeah, I mean, and then we've talked about this a little bit too, because I'm trying to help one of my kids' school think about, how do we come back? And you hear these stories about, I think everyone saw that CDC, MMWR piece on like the restaurant in China where there was an air blower that was blowing air across, and there was the, one individual who was infected, and then they lit up all the people around at the different tables who got infected. And so you don't, like, the last thing we want to do is like put a fan somewhere that, like, if there's a kid who happens to be infected sitting at that window, then you basically infect the entire room. Yeah.
Oh, that's crazy. All right. Well, we've only got a couple minutes left, and one of the nice things about this format is we have the ability to have people from everywhere, right? And we had a participant this morning named Susan, who also happens to be your mom, who had said that it was your birthday, and
happy birthday.
We would wish you happy birthday before we ended the webinar. So you're the first person that we've had with a birthday on here. You're also the first person to violate the FCC rules on 4-letter words. So I'm glad we got that one out of there. I can't thank you enough for spending the morning with us. This has been fantastic. You're amazing, and this has been great. Thank you so much.
Thank you.
All right, thank you.
Thanks, everyone. Tune
Call
in.
your mother.
Yeah, right.
While Ethan calls and chews his mother out.
Yeah, I'm not happy. All right, thanks everyone.
All right, thanks everyone.
Bye.
All right,
Happy birthday.
Thanks, Ethan.
Thank you, guys.
Thank you for tuning in to New York Bio's virtual breakfast series. Join us every Tuesday at 9 a.m. for more discussions with leaders from across the healthcare spectrum. For more information on New York Bio, please visit us at www.newyorkbio.org.